So, questions, please. Make these guys work. Come on.
I'll lead off on this then. If we have guidelines in the US now that state every 3 years for cytology alone, and that we know cancer rates go up when that gets extended beyond 3 years, but we live in a country where there's no organized screening, so we have no guarantee on when people will come in. How can we be sure that going to 3-year cytology screening intervals will not increase cervical cancer rates in the US?
The answer is simple. Organize your screening programs.
Yeah, I wish it was that simple.
About that? Could you give?
Just do it. It's not. I mean, yeah.
There are ways that it can be done. So most of it is paid for on insurance. The insurance could send reminders at 3 years. I mean, you don't have to go to a national organized screening program. You know, whether it's within an HMO or whether it's part of an insurance scheme, you know, you could actually, just as any recall, there is an invitation. It's normally short-term, you know, an invitation to colposcopy, but you could easily put something in place to send things. And the fact is that actually most women were coming back annually for screening without any organized program. So to get them back annually because they've had an abnormal, you know, they're HPV positive, I don't see why it is so difficult. Just, you know, actually formally following them seems to be difficult, but I'm not convinced that it would be so disastrous.
Can I make one other comment? One of the things I think is important to do is to try to embarrass the authorities into the fact that the United States is actually a third world country in terms of public health. And it is actually true if you actually look at...
You're insulting third world countries, by the way.
And I think, you know, if you look at vaccination for HPV, it's a scandal, actually. And really, I think that could be made more public.
All right, I'm shamed. I'm bye.
Politics aside, though, you're not answering the question.
Well,
and the question, no, I mean, there is a real question. They're clear politics, and they're clear what we should be doing, and I don't think anybody disputes your views on this. But the question, Jack and Peter, is if you have a non-organized screening program, would you be comfortable knowing that 20% of your patients are not routinely coming in for screening, to have a 3-year interval with cytology and a 5-year interval with co-testing?
It takes a lot of effort to get it down to 20%, I might add. 20% is not what happens in the disorganized section. And longer intervals equals more cancer. Hate me, but that's the truth.
I'd be interested in Peter and Jack's. Sorry, it's life's spot sometimes.
No, this is great. This is exactly what we need to discuss.
Now, what can be done in a non-organized country? The US is a non-organized country. Belgium also is a non-organized country, like many others in Europe. We have developed guidelines, recommended the European guidelines in Belgium, but reimbursement was not adapted to the interval and the age range, the general policy. Now, a few years ago, they have reduced the reimbursement in Belgium. It's reimbursed now every 2 years. Before there was no limit. There was just one limit. You could not have 2 smears taken the same day, taken by the same gynecologist. You had to go to another gynecologist or wait for the next day. Now, our guidelines were not followed, but now the reimbursement is, the interval is brought back to once every 2 years. This was a syndical compromise between daily practice, where it is annual, and the recommended interval, which was 3 years. And now we see that due to that reduction of the frequency in reimbursement, now 41% less smears are taken. So one thing that can be done in a non-organized system is to match reimbursement to scientific evidence.
Guys. Yeah, no. Okay.
I think there are a few things. First of all, we were actually recruiting for a randomized control trial when the guidelines came out. And the thing that was really interesting about it in the state of Washington was that clinicians changed. Reimbursement was part of it, because now they're only reimbursed if they screen women every 3 years, and there are checks in place to look at that. And I think the bigger component of this is really patient education. I think you just need to educate your patients. Women aren't stupid. They understand when you tell them that they need to come back in 3 years, and they can do it. I think the bigger problem, and then the other component of this is, since President Obama got reelected, we will now have a larger proportion, especially young women who aren't insured, who now are insured and will get access. But I think the big problem in the US is, as Jack said, we do have a group of underinsured and uninsured women, and that group, I think, is harder to reach, and regardless of interval, we just need to get them in.
Can I just make a specific comment to Tom's question? In our experience, when we looked at organizing in the UK program, I believe similar is true in the United States, is that saying that the screening interval should be 1 year versus 3 years has very little impact on women who choose not to come screening for all. You simply produce a large number of women who come every 6 to 12 months to be screened, but for those that don't get screened, whether it's 1 year or 3 years, has a minimal impact. So I'm not convinced that having a guideline that says shorter intervals has any impact on getting the women who don't get screened to come along.
Go ahead, Peter, and then I want to.
I live in Italy. In Italy, there is half of the population is organized screening program. Other half is paying by air pocket, not by insurance, but air pocket in the private gynecology. And so I think that there is a difference. One is the public health system that has to look at the healthcare in general. And in our organized screening program is going to, it's not now, but is going to use HPV testing alone every 5 years. This is aimed to reduce mortality and morbidity from squamous cell cervical cancer or cervical cancer, not other cancers. In the private sector, where women are paying by themselves, we are proposing co-testing every 3 years. Why? Because it's short-term interval and this double testing. Because the situation is different. So the main question is there a difference in the public health system versus the private system, or should be equal? And this is a very difficult question to answer, but this reflects the different in guidelines, the different environment, what the physician, what the private gynecologist do with the private patient at a single level of patient, or what is done at the public health level. So I think that the environment is very important and derives the guidelines, which are different based on the same data. We have the same data, and we use in a different way.
Peter, do you want to chime in?
So there's 2 points. One is that the data that Walter showed seems to be that when they changed the screening interval to 3 years, at least presumably that was Kaiser, actually women were coming back at 3 years, or only 3 or 4 months late. So I don't know whether, you couldn't really see whether there was a bigger proportion who weren't coming back, but it looks like it could be done. The other is, if you want to do something practical, you might say, well, with cytology it should be every 2.5 years, and with HPV testing or co-testing 5 years. The reason is that you would then tell women you really need to be screened at 25, 30, 35, 40, and you'd get that message across that on that 5-yearly birthday, go to be screened, so that there'd be less issue of losing track of when things were. That's one possibility, but I agree any change has to be carefully monitored to make sure that it doesn't result in actually a dramatic fall in the effectiveness of screening. But
that bar graph that I showed about the return rates, those were the people who actually came back. It didn't include the people who didn't come back. And with a lot of effort, phone calls, emails, chasing people around, we still have 20% of folks that don't participate in the screening program. And as you saw from the distribution of what happens when you tell people to come back at 3 years, there are a bunch of folks coming back in 4 and 5 years. I can put the slide up again if you like.
No, it's okay. I have many comments, but we're running behind schedule. So these folks have been thinking about this very hard, and there are interesting questions. Please approach them after the session. Let's go ahead and get on to the next one, and hopefully maybe we'll get a chance at the end to also discuss this a bit. No, there's no break in the.
Question?
Oh, okay, one more.
Yeah, I'd like to just to ask something about the last algorithm we've seen, because, well, you know, at WHO, and we are working on the screen and treat guideline, and the last, one of the last slides from Cuzick on the algorithm with HPV, starting with HPV testing and cytology. I'd like to know if you're going to validate this algorithm, if you're going to have more data to look at the impact of this type of algorithm, because we are going to recommend HPV testing as a primary screening test, followed by VIA and cryotherapy. And the huge question is to know how to use VIA and cytology as a triage test. So the more data we get, the more it will be important to get the recommendations right. So I really wanted to know how you're going to validate, or if you're going to validate this algorithm that you've shown to have the impact.
Validation is absolutely essential, and that's kind of one of the reasons why organized screening is so valuable, because in fact, you know, if you make these changes, absolutely essential to monitor the impact on, well, on a range of things, but primarily on the rate of CIN3 in cancer. And that certainly could be done in the organized programs in Europe, and essential. There's no issue about that. In other places, I think one has to create special structures to make sure that you actually are achieving what you set out to achieve.
I think we will have the opportunity to discuss this more in detail when we will have the guidelines from Latin America discussed. We have only addressed here the European and the American perspective, but yeah, the things which we have to consider now for developing countries, yeah, which screening test? Yeah, do we have evidence that HPV clearly is better than the VIA screening? And the next discussion is, should we triage with visual inspection? Which is, I think there is some consensus developed. That was also what you had proposed, Jack, in one of the previous HPV monographs. Or should we treat all the HPV positives, what was proposed from a trial in South Africa? So I don't think we have the time now to discuss this in detail, and maybe at the end of the next session, after the presentation of the Latin American guidelines, we can go deeper in that point.
You are